Hello again, everybody. I hope you're enjoying your meal. I would like to introduce Danielle Hartigan. Danielle, you're going to see a lot of today. Danielle is one of our track chairs. She's also an assistant professor in the Department of Natural and Applied Sciences, and she's the director of our Healthcare Thought Leadership Network. So please welcome Danielle Hartigan.
So I have the real pleasure today of getting to introduce my mentor and friend, Dr. Brad Hesse. So Brad has been at the forefront of really a variety of fields, including social cognition, communication, and health informatics for his entire career. And I'll leave the details to some of his background you can read about in our program. But currently, Brad is the chief of the National Cancer Institute's Health Communication and Informatics Research Branch, which I had the fortune to work with when I was at the National Cancer Institute. And here, Brad really helps to shape the direction of the field of health communication and health technology broadly. Brad also directs the Health Information National Trends Survey, or HINTS. This is a biennial survey that really monitors the public's use of health information and provides us with nationally representative estimates of health information seeking and health communication in the digital age. So it's been really a source of much of what we know about what's going on nationally in health communication. And Brad has recently completed, the report is coming out on the 15th, the President's Cancer Panel report on connected health and cancer. And so this report is really going to advise the President on how to bridge the gaps experienced by cancer patients and survivors in the 21st century with communication and technology. And Brad has authored or co-authored an astounding 170 plus publications. He has also just finished an edited volume called Oncology Informatics, Using Health Information Technology to Improve Processes and Outcomes in Cancer. So it sounded like a true labor of love. This work is really going to serve as the blueprint for accelerating progress against cancer through integrating health information technologies into what is a very complex cancer care system. And so, most kind of impressive to me about Brad, on top of all these amazing accomplishments, is that despite how prolific and distinguished his career has been, he is also a wonderful and dedicated mentor to the next generation of scientists. So Brad, thank you for helping to shape my development as a researcher, and most importantly, really helping to shape the science of health information, health communication, health informatics. So please join me again in welcoming Dr. Brad Hesse to Bentley today.
So what a privilege it is to be here. Thank you very much. One thing that Danielle does is she brings people together across aisles all the time, and that's what we've needed. Remind you, I'm coming here from Washington, D.C. This is so good to be to a place where people are having lunch, they're talking. Can we talk? I feel like Joan Rivers. This is very important. Well, when we're talking about a very complex system with oncology care, that's reflected. Oncology tends to have some of the big problems in all of healthcare. So what I'm going to talk about is going to be reflected with a lot of conversations many of you might be having in the health research space. And we need right now a different emphasis than what we can do sometimes at the NCI. And one of the reasons why we need that is because of the patients that we serve. I mean, something that I think a business sensibility gets is the notion of the consumer, the customer. Who's this really about? Who are we trying to be sure that they'll come back in healthy ways and we can continue to serve? I'm going to show you a quote by a good colleague of mine who passed away after her third cancer in 2014. Her name is Jessie Grumman. And she talked a little bit about what it was like in her 20s, was when she was diagnosed originally with cancer. And she said, the amazing thing is the tens of billions of dollars of medical research that have gone into creating these cures, and we are making progress on cancer. And all of that was on the shoulders of a skinny, frail, weak person in their early 20s who really would rather go dancing instead of staying back and taking her oral chemotherapy meds. A lot of this depends, the success, on the last mile. She also said this about the system in which she was embedded. She said and she had multiple chronic diseases, this happens a lot with our cancer patients, that often they'll consult with more than just one physician. They'll have sometimes 10 specialists, and to serve that cancer patient, we'll have laboratories. We'll have a lot of information that needs to be coordinated, and currently in the system, all that is being put on the shoulders of the patient with very little help. Here's an example. I'm going to give you a little snippet of a movie, documentary came out a couple of years ago. And just listen to this. You'll hear a little bit about how important this notion of connecting the system is. That's it.
Once upon a time in 2012, people believed their doctors could find the information they needed to take care of them. This was usually not true.
In certain parts of Memphis, Shelby County, like just about any city across America, there's a huge disparity in the ability to access just basic primary care, basic medical needs.
Well, life on the road is good, and but I tell you, once you do it, for a period of time, it get old.
We see the full gamut of healthcare needs here. That leads our patients often end up in the hospital sometimes. They're having to go to the emergency room for things, or having to go to other specialists around the city.
What if one of us got really, really sick on the road, and you have to go to a hospital and nobody knows you there? Then what?
Some people believe they already have the information about them. Some people don't want them to have the information about them, that is as a patient. But the reality is, in today's world, the primary way that data moves is a patient goes and says, I want my information taken to my provider. They get a stack this big, they take it to the provider, and the provider says, that's great, and never looks at it because it's not in a format that works for them, it's not timely, it just doesn't work.
Sometimes it was a nuisance when doctors didn't know something. Other times, it was deadly serious.
We thought that the surgical oncology group was monitoring that. I don't know if the outcome would have changed, but it's really hard to look back at the situation and not ask yourself whether or not things could have changed if they knew.
Many of you may know Don Berwick, who's in Boston. He's local. When he talked about this situation, he said, we have people in healthcare that are tremendously dedicated, are doing wonderful jobs. They're just not doing the right jobs. We need to redesign a lot of what the business of healthcare is in order to serve these patients. This sort of notion of a broken supply chain, that's rampant. This is the norm often rather than the exception. And this is what we're all trying to fix. And we need conversation, I think, across many disciplines to make that happen. And I heard there are people here who care about the user experience, formatting information in a way that people can understand it. There are people here who care about information systems, getting the right information to the right person or the right team at the right time in a way that they can understand it, in a way that's actionable. That's what we need to do to go from this, what is currently a fee-for-service transaction-based system, into a value-driven, evidence-based, and connected system. Now, I want to tell you a little bit about cancer, give you a little primer on where cancer is, just to bring you up to date on that. So cancer, first off, is not a disease. It's some 200 plus diseases when you take in all the genetic variants. Up until about 1993, we were losing the war on cancer. Make no mistake about that. We were losing. More people were dying every year, age adjusted, up until about 1993. What happened in 1993? Well, if you look at this chart on some of the more common cancers, the cancers that account for the most deaths, you'll see some interesting things. First off, you'll notice the peak, thank you, Philip Morris, of lung and bronchus cancer that finally started to turn down. It takes about a 20, 25-year echo effect from all the communication that occurred in the 1970s and 80s to help people understand that there was a link, thank you very much, between smoking tobacco and dying from cancer, and it was a strong link. So the latest data I saw is that we're down to about 15% from the CDC, of the national population smokes. That's actually an incredible reduction from when we had over half the adult population smoking. We've made tremendous progress. That's what that line is about. But there are other lines too. Notice back in the 1930s, people don't talk about this very much, but stomach cancer started to go down. Some of you may know why. It's because we had better public health. And we protected people from H. pylori infections, which would cause cancer often. And then notice colorectal cancer and prostate cancer. These are cancers that we can screen for. So keep that in mind as we talk a little bit more about it. It's a similar sort of trend in females. Notice that women, in spite of the Tareyton advertisements of the 1970s, didn't smoke as much as men typically, but at the same time haven't come down as quickly as men have either, so we're still concerned. But we also see some reductions in breast cancer, uterine cancer, and then the typical one in stomach earlier on. So what does it mean to reduce the disease burden of cancer? I want to give you the pathogenesis of cancer for a minute. So imagine that if you think about the typical body, and cancer is simply a malfunction of genes replicating, is that we go through a period where we don't really have any cancer, we don't have cancerous cells, we're exposed to an environment that could give us another hit if we have some kind of genetic susceptibility to it. And when we get that hit that's a carcinogenic hit, like smoking tobacco, then we start to see these mutations occur. That area of susceptibility, we can prevent some cancers, and we'll move on that. That becomes our first line of attack. Now, I had a number up there, about 595,000 expected to die. This is from the American Cancer Society this year from cancer. That's about 1 in 3, 1 in 4 will be touched by cancer in this room. We can prevent, we think, anywhere between 30 and 50 just by doing a better job of prevention. And many of you know that in the legislation that's pushing from the CMS toward accountable care, prevention is on the docket as something that we can do better in our healthcare system. That's why. So even though we race for the cure, and we all want the cure, prevention is number one. If we move on to the second place where we have early initiation of what are cancerous processes, neoplasms, if we can look at that, detect those, and excise them before we get metastasis, we can also eliminate probably another 15 to 20%. So here are two areas where we can do a lot of work, and we haven't touched the cure yet. If we move forward, we have a lot of drugs now that will even allow us to control the behavior of some cancers so that they won't necessarily kill you, thank you. We'll keep them under wraps so that we block metastasis. We keep the cancer at bay. It becomes chronic. But with vigilance, following people, they can live very long, healthy lives. That may account for another 15%, maybe up to about 70%. Remember that number. Now we talk about the moonshot, which is one of the few bipartisan discussions that is happening right now in Congress in Washington, D.C. That's Vice President's moonshot on reducing cancer, accelerating in 5 years what would otherwise take us 10 years to do. And that is focused on getting better cures, which will drive us down even further. But on the business side, I want to think a little bit about what happened earlier on in that film, the examples of disconnected health. Danielle mentioned a report that's coming out by the President's Cancer Panel. There's a panel that's empowered by legislation from the Act in the early 1970s. And the panel is supposed to look at the whole National Cancer Program and then give a report to the President of the United States to say, here are where there are gaps. Here are where there is an interest and a need for research and a need for change in the way we do business. They chose the topic this year of connected health. Some of you may recognize Hill Harper, actually. He's an actor. I think he was on Limitless was one of them, and he was also Covert Affairs and any of these shows. So we always have someone, he's a cancer survivor. I think he was from Harvard, as a matter of fact. That's where he got his JD. A brilliant contributor, someone from the popular sphere in addition to the academics that the rest of us sometimes represent. But this report, which is coming out on the 15th, November 15th, is going to be filled with recommendations. It's embargoed, so I can't tell you specifically what they are, but let me show you the diagnosis that they uncovered. Think about these areas of opportunity. Something as simple as smoking. In the pre-2009 world, about 70% of smokers who visit healthcare situations receive very little follow-up. They're lost. I mean, you write it down on a piece of paper, it's a stack of papers, no one knows what to do with them. They're lost to the system. And they end up being casualties. That's a disconnect. I remember looking at some data that a colleague of mine collected. This was in an insurance system in North Carolina. And in that insurance system, these are people who have access to care, and they were presenting with late-stage cervical cancer. No one in this country should be dying from cervical cancer. We have a good early screen on that. Who are the people that were presenting with late-stage cervical cancer? There are people who didn't get their pap smear. No one tapped them on the shoulder and said, it's time, because we had a fee-for-service, busy kind of environment where we didn't do that kind of thing. And we have other examples of this loss to follow-up. We're now pivoting to not clinically based chemotherapy as much, but more oral anti-neoplastics. So this is going to take adherence in the house, in the home. If you give that to teens, 68% of teens tend to be non-compliant. They have a hard time adhering to that regimen. And then we have survivors, where Danielle had studied a lot. These are people who have made it through with a clean bill of health. They've had the wonderful support of the team. And then all of a sudden the team says, thank you very much, here's the bill, good luck. And they're on their world and they're lost in transition. Meanwhile, they've got to be vigilant for secondary instances of cancer. They've got to be vigilant for what may happen as a secondary effect from their chemotherapy, let's say, or radiation. And we sometimes lose them. If we go to the Joint Commission's Sentinel database of errors on a human factors perspective in the healthcare system, we see that the highest number of errors is attributable to dropping the baton in terms of communication. These preventable errors are exceeding somewhere in the realm of 17 million each year is what's expected. There have been estimates of 100 to 400,000 deaths because of medical error. We go beyond that in thinking about medical error in cancer because the deaths are typically errors of commission, but we worry about errors of omission. I forgot to tap you on the shoulder and tell you about that pap smear. Oh, you turned 50. Really, a colonoscopy is a pretty easy way to be sure you live for the next 40 years. Those are errors of omission. So this is what led the president, the CEO of the American Cancer Society, who's now retired, John Safran, to say we know what kinds of things need to be done to increase the number of people who survive from 350 per day to 1,000. We know that now with current medical knowledge. That's why those numbers added up to 70%. We can do this now, and those are big numbers that we can save. But we need help, because it's not looking at a new drug, it's looking at systems. It's looking at business. Meanwhile, back at the ranch, we have an aging baby boom I'm proud to be part of and want to continue to be part of it. But when that happens, cancer is often a diagnosis of aging. We're going to hit our system with more people than we've ever anticipated before. We're also going to get an increase in other kinds of chronic disease if we're not careful and we don't intervene soon. We're going to get more complexity through precision medicine in our care. We're going to get increases for disease and remission. We're going to get a shrinking workforce, rise in treatment costs. Where are information systems people in this room? We need you. We need you emergently, and we need help on this because we have to support a lot of people. The treatment, we said, is going to be in smart, connected health. And what I want to do is I want to share with you some investments that we've made. This goes back to a report from the President's Council of Advisors on Science and Technology. They said in order to achieve the nation's goal of improving people's health, we need to make a fundamental change in our healthcare system. We need new approaches, especially to manage chronic disease. And this must be an approach in which individuals are brought into the system and they're partners in every aspect of their care. We know that we have to get the right knowledge and information to drive the appropriate actions. That's what's missing in the current version. Now, we actually invested in a research funding program with the National Science Foundation. I think some of you might even be funded by the National Science Foundation. This is called Smart and Connected Health. And I want to share with you some of the aims of that because it gives you a feel for how we want to change the system. So in industrial age medicine, we were focusing primarily on episodic care. It was reactive care. Someone came in with a symptom. The trouble is that symptom meant that the disease had gone too far. And so there was tissue damage. It was hospital-centric. We didn't think about taking people and helping them heal in their home environments, which is often a much better environment. It was training and experience-based. You individually are the sole arbiter of all the information because you are the MD. And there's just too much knowledge to stick in anyone's head these days. We had fragmented local data. We have naive, passive patients. And these were the results that we're talking about. This one-size-fits-all approach doesn't work. We have rise in cost that's unsustainable. We have an escalation of chronic disease. We have an antagonism between clinical and public health. I would say an antagonism unnecessarily between business and the health system, between business and academics, and we need to overcome all of that antagonism. So what does it mean to move toward this kind of smart, connected health, this information age medicine? I'm going to go about each one of these and show you some of the investments that are already starting to pay off because these are opportunities of innovation that we can start thinking about. One, the quantified self movement. One of the biggest, I think, gifts given last Christmas was the Fitbit. It was the most popular consumer item at the time. To me, that does my heart good. It means people really care about getting on top of their health. We're creating a culture of health. Granted, about 4 months after that, most people broke their New Year's resolutions, including me sometimes. But I keep coming back, and that's what's important. But this notion of having these devices that are wearable and that are recording information will also help us as we try to understand the travels of individuals who are becoming healthier. People desire now to share their data for personal good. This is a program by Robert Wood Johnson that's doing that. And in sharing it, here's a funded project that we had in Southern California. Here are people who with asthma. They would sense air quality using mobile phones. This is the core of citizen science, actually. And they would put that up onto a grid where they would warn other people with asthma where bad air quality was occurring. We couldn't do that from the top down with NOAA. We did it from citizens up. And we have new challenges for us now because patients are telling us, okay, I'm tracking my Fitbit. My doctor told me he wants me to lose 20 pounds, and I'm trying my darndest. Can you review this? How can we get that back into the medical record? And there are ways of doing it. We're seeing some bright spots, but we're working on it. And that whole notion of someone who is communicating with an office and we're delivering care at point of need rather than point of care, that's going to be another emphasis, I think, in the years coming up. So telemedicine's been around for a long time, but I know many of you are engaged in telemedicine because there's a resurgence. We have the technologies to make it happen. We have the business need to make it happen. And some of what we can do is we can take something like this is developed at MIT, and many of you know about the smart Internet of Things objects. There are some really beautiful kinds of devices that are being used now to help people keep track of their administration of medications. And we can even start taking this and embedding in houses. So that same asthmatic, I was talking to someone at the FCC, they're working on sensing air quality control in houses and putting in the appropriate medication as a mist into the house when certain levels fall low. There's a lot that we're just seeing that we can do. This idea of electronic medical records, which I guess the president of the AMA referred to as being snake oil at one time, never short of opinions. And I heard him speak at HIMSS in March, I think it was, of last year. Actually, very critical. The trouble is the versions we have now are Betamax, and we live in a Blu-ray world. We need a lot of work to make these things. And we do a lot of studies with physicians and say, can we take it away from you? And say, oh no, but make it better because it's not working really well. That's going to give us data to make decisions, and that's going to be the key not just at the individual level, at the individual patient level, but it's also going to be the key higher up over the entire hospital. We're going to be able to start looking at communities from that, and there's a big tax incentive to do that. Hospital systems are going to start doing better public health than the CDC is. And as we do that and we start connecting, any of you who know about Siri and Watson, know that as we start getting real algorithms operating in the environment, we can update those algorithms automatically with real-time decision support. What we're doing is we need to push, and there is work from the Department of Health and Human Services to make interoperability a reality by 2020. As we make interoperability a reality, we're going to get access to our records anywhere, and that's going to be key. But this is an interesting piece as well, and this is from someone local in Boston at the Children's Hospital, Ken Mandel, if any of you know Ken. Ken made a proposition a while ago. He said, you know what, these electronic health record systems, the reason why they're not very useful is because they're old accounting systems, they're old billing systems. That's good, they just weren't set up for clinical care. So the question is, how can you build on top of them? Think of the electronic health record like an iPad. How do I build apps on top of them? And why does he want to do that? He wants to create an ecosystem where the market starts determining usability for individual kind of customer niches on top of the electronic health record. This is where we're going right now. That means we're going to start moving toward innovation and invention, and we need people to help us in that process and think about how to disrupt things in a positive way. And as I mentioned earlier on, the big notion of the big flip from industrial age medicine, and we saw this with the web, patients were coming in before docs were ready for it. The patient is going to be the top of the pyramid. It's going to be the one who's very crucially engaged because they know their own symptomology and bodies and the people that they've interacted with the most. And what we're going to do is we're going to allow physicians to operate in productive ways with those active, prepared, and engaged patients. And as we do that, we have to think about patient rights. There are a lot of stories about people who said, I'd like to get my electronic health record data, please, and they said, no, you can't have it. They took them to court. Lance Armstrong did this. Lance freaking Armstrong. And then finally, of course, they had to give it to him. You do have a right to your data, and it needs to be given to you in a prompt fashion. I just want to give you a case in point before we wrap up. This is from the book that we were talking about, and what was wonderful about this is we brought people in from around the country to contribute ideas of where they were using systems to improve cancer care. One is from the American Society of Clinical Oncology. They have now been able to bring most of their offices, those that elect to join this system called CancerLink, and they would send up their treatment decisions and their office data on a daily basis, so that individuals practicing in Duluth can see what's happening in Boston and figure out what to do with patients that emerge that they've never seen before and get comparisons. And all of this is for quality control. And a lot of work is happening with that. I mentioned before this notion of population health. I remember when someone was talking to me about the HITECH Act, the Health Information Technology for Economic and Clinical Health Act of 2009. And it scares me, I know that. When they were talking to me about that, they said, hey, the big shift is that we're going to allow doctors to be responsible not just for one patient, but for everyone that they're serving in their office, and hospitals to be responsible for the catchment area. And that's how we're going to tackle disparities. Thank you very much. We're going to move toward precision medicine, and that does have a lot of implication for how we serve up that information and how we treat people, but it is going to increase, I think, the efficacy of our treatments. I'm also worried about how it might increase our costs. We need someone to be thinking about that. And a lot of this depends on data altruism. Patients who are willing to contribute their information back to the system for precision medicine. We had a wonderful contribution from a primary care doc that explained how patient portals can be used in a way that is proactive and tells people about that colorectal cancer screen they need, or the mammography, and maybe send a little text message along with that. And very interesting. We moved as well to the notion of mHealth and what telemedicine might really mean in the context of care, and how we can get reminders on our cell phones when my table is ready down at the local restaurant, but no one's telling me when I can go in and see my oncologist. Thank you. What is this about? And so we have places this is at UC Davis in California, where we have a bright spot of that occurring. In the Kaiser system, by the way, It now turns out with data from 2003 that almost half of our visits are occurring through either secure email or telephone. These are mediated conversations. Now that means people get the information they need when they need it, but there's also a change in the communication environment. Good research area, Daniel. We talk about the continuum. I did that earlier on. We brought some wonderful people in to show how we can take that smoking rate, for example, and be sure that no one is lost to follow-up when it comes to smoking. Steve Taplin's the one who did the research, by the way, on the Pap smear, and he's been able to get increases in Pap by just tracking that with electronic systems and then sending messages as appropriate. We're starting to use more data and big data to drive our diagnosis and treatment, and that's what Amy Abernathy is doing with Bradford Hirsch. Amy does a lot of work with Flatiron. She's an oncologist out of North Carolina, Duke. And then a lot of work being done in survivorship and even at end of life to prompt those conversations about palliative care and about hospice care. Important conversations and getting teams centered around that. We have people who talk about supportive behavior. There's even this guy, Bradford Hesse, who talks about communication and how we can use these systems as there really should be in care, and that is to stop those batons from dropping, to make a good communication system. We're even changing the way we're doing surveillance. So the way that we keep track of people, we're not going to wait until you die. We're going to have it from point of diagnosis on and learn more about your trajectory, follow your symptoms, improve our medication at an accelerated rate. And we were late to the game. So we invited people like Smart Patients out in Silicon Valley, or patients like me in crowdsourcing, local in Boston, and other aspects of big data and cyber infrastructure. We invited them to tell us of where we can skate into the next 10 years. And from all of that, we extracted out some bright spots, and we looked in a post-high-tech world, because high-tech is going away. It's being replaced by MACRA, which is the Medicaid and Ship Reauthorization Act. And in that world with value-based care, the notion is to get all this technology seamlessly in the background to emphasize care, reduce cost, increase population health, the triple aim. And I would say there's been a migration to a fourth aim, which is not to burn out our poor doctors working in the system. Takeaway points: medicine and public health are evolving rapidly. We're going from old medicine to new medicine. In this new world, data will be the currency. We need to innovate our healthcare system. New tools are emerging all the time. We need work on data visualization to be sure that we can make true decisions and business case decisions about how to treat people across entire systems in a good way. We're going to start combining data from across systems, which has been difficult to do, but we are starting to make progress. As I said, by 2020 is the goal. We're going to get better examples of these data flowing through the system. Change is pervasive, but it's not about technology. It's a culture change, and I would say it's a system change. And it's that social change project. This is David Blumenthal used to be the national coordinator, also in Boston, one time anyway. All of this, according to Vice President Biden, is going to require open minds, open data, and open collaboration to pull off. And I would argue that the goal here is to bring the business of healthcare finally into the 21st century, following the leadership of people like Elon Musk, Steve Jobs, and of course, Daniel Hardigan. Thank you very much.